Thank you. And Dr. Henningfield is a PhD professor at the Department of Adjunct Professor at the Department of Psychiatry and Behavioral Scientists at Johns Hopkins University, Vice President of Research and Health Policy and Abuse Liability at Penny Associates, former Chief of the Clinical Pharmacology Branch and Biology of Dependence and Abuse Potential Section at NIDA. He has 52 years of research of experience in this area, and we welcome Dr. Henningfield for his presentation. Jack, we're not hearing you. It may be that you're muted.
Okay, I should have had my coffee first, which I'm dependent and tolerant on. Now I'm ready to perform. Thank you for the opportunity. Next slide, please. By disclosure, I've been working in abuse potential assessment for half a century, and I continue to do that for a variety of sponsors of new drug and dietary products. Next slide, please. By a quick overview of my presentation, as you've already heard, both the DEA and NIDA and the U.S. Department of Health have concluded that Kratom does not meet criteria for scheduling, and they also considered public health factors. A, that there was not an imminent public health threat posed by Kratom, and B, that banning Kratom could risk increased overdose deaths. And let's see, what I'd like to just comment on briefly in the next few minutes is new research that helps understand Kratom's low abuse and risk potential. The new research also suggests overall greater societal benefits than harms, and I think that's a picture that is emerging from work in Malaysia, around the world, and as you just heard some of that from Dr. Smith. New research, and this is really exciting, is helping improve understanding of the mechanisms of action and also provide the foundation for regulatory approaches, such as product standards for alkaloid contents and standards for contaminants. And Dr. McCurdy's group has really been a global leader in that. So Drs. Hustis and Smith have just presented examples of some of these new research findings. The research pipeline is quite frankly gushing, and it's really exciting. NIDA, National Institute on Drug Abuse, deserves a lot of credit for that with its funding. Next slide, please. So here's a study from Malaysia, the Center for Drug Research at University Sains, Malaysia, that actually they've done a lot of field studies, and their results actually overlap very nicely with the results that Dr. Smith had just shown you and several of her earlier publications. And if you look back, she's done quite a few publications in this area. And in one of their studies, recently published, they looked at 332 male patients in drug rehabilitation, and they interviewed them with a semi-structured questionnaire. Over 2/3 of the respondents had used Kratom to alleviate heroin withdrawal and reduce methamphetamine intake, which is a major problem in Southeast Asia. 59% used Kratom as a substitute for heroin and methamphetamine. 15% used Kratom for its euphoric effects. Next slide, please. Now, because Kratom withdrawal and dependence is discussed quite a bit, and often it's referred to as though it's opioid dependence, despite the evidence suggesting that that's an oversimplification, we convened an international global forum that included participants that have done leading studies over the last several years. And this includes 8 animal studies, 2 human studies, and multiple surveys in the United States, field studies in Malaysia, and mechanisms of action. This was just appeared ahead of print online and is available from Drug and Alcohol Dependence Reports, one of the journals of the College on Problems of Drug Dependence. And you can see the 16 or 17 researchers from around the world involved in that forum. Next slide, please. A couple of the main forum conclusions. First, very high relative to human consumption, doses of chronic mitragynine can produce withdrawal in several animal models. Second, withdrawal is generally weaker, less prolonged, and not qualitatively the same as opioid withdrawal in animals. Next, mitragynine can dose-dependently relieve opioid withdrawal in animals, and its benefits in one study were comparable to using methadone or buprenorphine. In humans, this is really interesting. Kratom is not reliably observed in moderate intake daily kratom users in studies or in the real world. Withdrawal is more likely in kratom users with former opioid use history. And so we've got to do a better job when somebody says, I'm having withdrawal, is asking, did you have an opioid use history? Withdrawal is more likely with people that use kratom more than twice per day, but again, is still not reliable. The mechanisms of withdrawal relief might be partly relieved by alpha adrenergic and serotonergic effects, as is evident with clonidine and FDA approval of lofexidine. By the way, that's the first non-opioid approved for kratom withdrawal. So we should be judicious treating kratom withdrawal with opioids. Next slide, please. A really cool study, again by the University of Sains, Malaysia, looked at the cold pressor test and withdrawal using the cows and sows. And again, they found what others have found. Kratom does relieve pain, increase pain tolerance, and there was no evidence of withdrawal post-study, and that was in people who are heavy chronic kratom users. Next slide, please. An animal study showed that naloxone precipitated withdrawal in both very heavy morphine and mitragynine treated rats. However, the scores were significantly higher in morphine, and anxiogenic behaviors were not present in the kratom group, suggesting that anxiety is not a kratom withdrawal effect, which it is for morphine. Next slide, please. And different studies have looked at the lofexidine and alpha adrenergic effects. And Dr. McCurdy's group has looked at this, a number of groups have looked at it. And in fact, kratom mitragynine in animals discriminates and generalizes more closely to lofexidine than it does to morphine. And remember, there's a myth that kratom relieves withdrawal. It must be an opioid. Well, you don't have to be an opioid to relieve opioid withdrawal, as we know with the FDA-approved drug. Next slide, please. And finally, this is a really cool study. There's a lot of studies on the signaling pathways of kratom, and NIDA funded this study, and NIDA put this study on its website as a research highlight. And to put it all in a nutshell, both mitragynine alkaloids on the left and morphine-like opioids on the right can produce some benefits and some effects like constipation, anti-fatigue in the case of kratom, and pain relief. But kratom takes the relatively safe route, which is not increased beta-arrestin, and is a biased partial mu opioid agonist. So it's not just what you do, it's how you get there. And mitragynine gets there in a safer way. Last slide. So, in conclusion, earlier findings of low abuse potential, lack of public health threat, and evidence suggesting public health benefits support continuing access to kratom, not placement in Schedule 1. And remember, placement in Schedule 1 generally requires evidence of high abuse potential and known or imminent public health threat, which has not been demonstrated, and quite frankly is contrary to what we're seeing in surveys. New science supports earlier conclusions by DEA, NIDA, Department of Health and Human Services, and the WHO Expert Committee. New science is also laying the foundation for regulation and ongoing new medicines development on substances derived from kratom, but this is probably a 10-year pathway. Now let's turn to Dr. McCurdy, whose group is really the global powerhouse now. And he's going to show you some of his research from dozens of studies that they've published just in the last 2 years. Dr. McCurdy or Mr. Haddo?